last talk of the day, for which I have the honor of introducing myself.
And Professor Basu needs no introduction.
No, the next one. Yeah. Second one, second from top. Yeah. Second one from top. The second one. Yeah. So good afternoon, all of you. I'm glad to see so many people over here. So I take it that all of you are deeply interested in learning about uveitis. I come from LV Prasad Eye Institute. This is not moving. Okay. Right. So why is anterior uveitis important? Most likely, majority of the people sitting here are general ophthalmologists, and in a general ophthalmology clinic, more than 90% of all the uveitis patients that come are likely to be anterior uveitis, and even in a tertiary care center, up to 40% of all patients are likely to be anterior uveitis. And it's not an innocuous condition. If we treat it inadequately or diagnose it inappropriately, then it can result in very significant visual and systemic complications. Also, the fact that a lot of cases of panuveitis and intermediate uveitis may have a component of anterior uveitis which needs to be recognized. So what I'm going to discuss here is a three-step approach that should be useful to the general ophthalmologists who are sitting here. This is not a comprehensive cover of anterior uveitis. There are some of the forms that you might miss through this approach, but this should be able to cover majority of the cases that come to your general ophthalmology clinic. The first step is to confirm that you are actually dealing with anterior uveitis. The second is to look for the presence of granulomatous keratic precipitates, and these are the ones that have a volume. They are not just pinpoints on the endothelium, they have a volume. Those are the granulomatous keratic precipitates. And the third one is, if there are no granulomatous keratic precipitates, then ask for a history of inflammatory joint pain. So I'll cover these things in detail as we go forward. So what should be the first thought when you see a patient who has been told to you to be having anterior uveitis, or you get an impression that this might be anterior uveitis? The first thing is to rule out what is not uveitis. And as simple as this might seem, this is very, very often missed. Very commonly in patients at the extremes of age, patients with a history of trauma, which might be trivial, history of drug ingestion, and always keep looking for something which looks different. For example, if you look at this eye, there is hardly any circumciliary congestion. And if you look at what appears like a hypopion, you will see that there is a lumpy, bumpy kind of appearance of that hypopion. So no circumciliary congestion, a lumpy bumpy appearance, you might be dealing with something else. And this particular case happened to be a patient with leukemia. So also, rule out the other causes of red eyes. Many times you have conjunctivitis being confused as uveitis and vice versa. So once you have made sure that this is truly uveitis, you have to find out the primary focus of inflammation. And again, easier said than done. Many of the patients, if you do not examine the fundus properly, we might just call it as anterior uveitis and keep treating the anterior segment while the disease progresses in the posterior segment. So it's never anterior till you have seen the fundus very carefully and not just a cursory examination. Now, this was a patient who presented with mutton fat keratic precipitates, and the first person who saw this patient just saw the posterior pole and missed out this large retinitis lesion that was lying in the supratemporal periphery. This was clearly a case of toxoplasma retinochoroiditis, and it would have been disastrous if we had just treated the anterior segment of this patient. Another point to highlight here is that we often talk about spillover inflammation into the posterior segment or in the anterior segment, but remember, it's not exactly spillover, but the cyclitis which leads to the inflammation in the vitreous, which you see in patients with anterior uveitis. So once you have made sure that you're dealing with inflammation with anterior uveitis, where the focus of inflammation is in the anterior segment, look for granulomatous keratic precipitates, KPs with a volume and not just flat endothelial dusting. Very simply, this helps us in ruling out what is non-granulomatous. Now, this sounds very obvious, but if you keep this in mind, you won't investigate for the wrong etiologies. However, there is a very important caveat here, and the caveat is that all granulomatous anterior segment inflammation starts and ends as non-granulomatous. So, for example, if your patient has already been started on topical steroids by the previous ophthalmologist, by the time you see this patient, those KPs would have gone. And then you might get a false impression of non-granulomatous, while actually the disease was granulomatous, which you will know if you look at the previous records of the patient. So what next if you think it is granulomatous anterior uveitis? There are basically three categories that you want to classify into. Of course, there are several other causes, but for the benefit of this audience, I'll stick to three important categories. The first category are two most common causes of granulomatous anterior uveitis in our country, and these are tuberculosis and sarcoidosis. Now, iris nodules, this one has very florid iris nodules, but there are other patients where you may have to examine very carefully for the iris nodules. One feature that we see commonly in our sarcoid patients are the presence of these peripheral anterior synechiae. These are tented synechiae, which are very suggestive of sarcoid in the correct clinical setting. Also in our country, may not be in other populations, we see these discrete hypopigmented spots in the inferior peripheral fundus in our sarcoidosis patient. There is no other posterior segment inflammation except these spots. So if you see those, think of sarcoid. And finally, the tuberculin test is useful not only in the diagnosis of tuberculosis, but a negative test may help you in the diagnosis of sarcoidosis as well. So in these patients, you look at the chest radiography, preferably with a CT scan, ask for a history of TB contact, look for other evidence of systemic TB, including other extrapulmonary tuberculosis, look for evidence of systemic sarcoid, and remember, the diagnosis of sarcoid is not based on getting a serum angiotensin converting enzyme, but by finding organ specific involvement of sarcoid, which could not only be in the lungs but also be in the skin or in the CNS. And finally, Dr. Kalpana is sitting here, so getting a Schirmer test might be useful because dry eye is a characteristic of sarcoid, while the absence of a dry eye would suggest tuberculosis in case your diagnosis is in doubt. So this is the first category of granulomatous anterior uveitis. The second one, again, which is very commonly missed if you do not examine the fundus properly, is its association with panuveitis, especially those patients where it's a recurrent form of Vogt-Koyanagi-Harada disease or the sympathetic ophthalmia. So just a easy fundus examination of this patient will show you this sunset glow fundus, which will take you to the diagnosis of leakage in these patients. The third pattern that you need to identify is that of viral anterior uveitis, and these are more commonly due to either herpes simplex virus or varicella zoster virus. Now, the two P's that you need to remember for viral anterior uveitis are pigment and pressure. If you see alterations of pigment, the keratic precipitates are pigmented, you see an iris atrophy where pigment has been lost, or you see pigment dispersion in the anterior segment, think of viral anterior uveitis. Similarly, raised intraocular pressure should also guide you to the diagnosis of viral anterior uveitis. Now, this is a patient with a very obvious herpes zoster ophthalmicus. You can see the scars on the skin. You see the sectoral iris atrophy in this patient on the lower left hand side, showing the sectoral iris atrophy suggestive of zoster. Sometimes the iris atrophy may not be very obvious, and you might see just a D shaped pupil, as you can see in the picture on the top. And then there's a category of where there is not much inflammation like you saw in the other pictures, but the intraocular pressure is very high, and that is cytomegalovirus anterior uveitis. I'm not going into the details over here. Now, this is one last category, and I hope many of you have already recognized this condition. This patient would not have had any history of redness or pain. He or she would have come to you with a history of decreased vision, or sometimes with a history of floaters. And you see these diffuse KPs on the corneal endothelium, and this will lead you to the diagnosis of Fuchs uveitis syndrome. Remember to do a good counseling for the possibility of floaters post-operatively if you are planning for cataract surgery in this patient. The other causes of white eye anterior uveitis as well, apart from Fuchs, Behçet's disease, while it may have very significant intraocular inflammation, there is not much of circumciliary congestion. Similarly, juvenile idiopathic arthritis in children, and all the masquerades will generally not have any red eye, as you see in other forms of uveitis. Now I'm coming to the last, and I've saved it for the last because this is probably the most common cause of anterior uveitis you will see in your practice. These are the patients who will have an acute onset of uveitis. The disease will typically be unilateral or alternatingly unilateral. Professor Zerut used to call it a ping pong kind of presentation. Then there's a history of inflammatory joint pain. What is that? The patient has a history of pain which is more when he gets up in the morning, and then as he starts moving around, the pain is relieved. So when you're talking to a patient of uveitis, don't just ask for joint pain, ask for a history of inflammatory joint pain. Like you see in this patient, you might see fibrin in the anterior segment, and always the posterior segment, apart from vitritis in some of these patients, would be normal. In these patients, you would test for HLA-B27 because that is very likely to be positive. If you get it positive in this kind of a presentation, you don't have to do any other test in these patients. You can inform the patient about the course of the disease and can refer the patient timely to the rheumatologist in case there is a history of inflammatory back pain or any other joint pain in these patients. So some other clues that, details that you should know, because this is probably the most common etiology of uveitis that you'll make in your practice, irrespective of wherever you are practicing, is that some of these patients will have a history of prodrome. So they'll know that this disease is coming. And, this is very useful when the test is negative in some of these patients. The intraocular pressure, if the patient has been untreated, is typically low. A high intraocular pressure means that the B27 is very, very unlikely. And as I told earlier, if you see vitritis, it doesn't mean a spillover inflammation, but it means that the disease is essentially an iridocyclitis and not an iritis alone. So the cyclitis will naturally lead to the vitritis in these patients. The HLA-B27 is positive in most cases of ankylosing spondylosis and other spondyloarthropathies, while it is negative in other diseases like psoriasis or inflammatory bowel disease, where you may also see a chronic course with a posterior segment inflammation. There are certain triggers of the disease that you should be aware of. Many people, it gets triggered by stress, including inadequate sleep, and in some settings it gets triggered by seasonal variations as well. And finally, the treatment for the systemic disease also has a relevance for the ocular disease, because some of the treatment like sulfasalazine or methotrexate or the TNF inhibitor adalimumab will have a reduced rate of recurrences, while if the patient is using etanercept, and you have to ask for it, the trade name is commonly Enbrel, there is a chance that it may exacerbate the ocular disease, while relieving the systemic disease. So coming back to the three-step approach again, confirm it is anterior uveitis. There is no diagnosis without a thorough fundus evaluation. Look for the presence of granulomatous keratic prespirates, including iris nodules, peripheral anterior synechiae, the pigment and the pressure, the fundus for the sunset glow and the distribution, the diffuse distribution for the Fuchs, and these will all lead you to the different patterns of diagnosis that we just discussed. And if your KPs are absent, then ask for a history of inflammatory joint pain, and with an additional history of ping pong presentation, fibrin in the antechamber, normal fundus, this will lead you to the diagnosis of B27 anterior uveitis. Thank you for your attention.